This was the AI voice this year, where we had a session on retina with the glaucoma instruction course, and where we required a VR perspective or how is the retinal perspective when they see a case of a glaucoma. So, where does the two departments merge and where are we concentrating? That was the thing. So, it started with a case. It's a normal mild diabetic retinopathy changes which you observe in both the fundus. You see a little more detail, you see a little more changes more on the left side than the right eye. She just came with a slight blurring of the vision, but the vision was still 6.6, 6.9 and all. Angles were open, and we thought we can just observe the NPDR and baseline. Some of the glaucoma workup was also done. Was all normal. She was already using AGM from outside when she was referred to, and we saw that there is some change in between the two eyes. So we thought we'll just have a little more close follow up rather than normal follow up for NPDR is how much? Every 6 months. So we need to follow it up little earlier. And next 1 month later, when she came, the vision was little further down in the left eye, and the pressure started increasing even in both the eyes. Angles were open. This FFA is actually for the next slide. So, but you can just see, I'll go back here. So again, we had a little suspicion, but we just wanted to watch. A month later, she came with a high pressure and a pain. The angle started having a little closure. And at this point of time, we had to confirm the diagnosis by this type of angiograms. So angiogram was done when the right eye angiogram was almost showed the similar clinical features, whereas the left had a little more leakage. If you see in the late phase, there is some perivascular leakage, but the corresponding OCT showed a compact retina. There was a asymmetry between the leakage here. So that prompted us to think that okay, there is something going on in the related to neovascularizations. So the clinical diagnosis at this point of time, we do it as NVG. And when there is a neovascularization, either in the retina or in the iris or in the angle, we are supposed to start with the laser treatment. That's the treatment protocol. So we started with when there is such macula compact vision good eyes, we usually start the laser from the periphery. So we usually advise for the peripheral PRP, we call it as, not the laser mark should not come into the posterior pole. That's how we start with. But again, had a close follow up. So by 6 weeks follow up, the vision further little dropped down and the pressures were high still in spite of AGM. And here we started having the suspicion, okay, we might be dealing with an ocular ischemic syndrome because one eye is completely behaving differently. And carotid Doppler was done, which showed almost near total occlusion of the lumen on the left proximal one. So this is what we got it, and it was quite it's something scary, which started with a simple vision and then which went into such a serious systemic issue, and an immediate neurosurgeon had to see this. So by that time, when they did a MRA, they could see a lot of collaterals in the circulation, and they don't usually do any surgical intervention. They manage with the antiplatelets. So this is how the seriousness when we not pick up the subtle changes. So this comes to an extent that what is that retinal pathology which is causing the high pressure? Okay, so that we call it as secondary glaucoma. Secondary glaucoma is, one need to remember that it's frequently arises from the posterior segment pathology, and a vitreoretinal evaluation is crucial for an accurate diagnosis and its management. So what are all the secondary glaucoma one can think of? So it can be a neovascular glaucoma, that is ischemic, can be inflammatory, can be trauma related, and a separate entity we call it as malignant glaucoma. And any surgery, VR surgery, can have an association with the glaucoma genes. So focus of the talk was to have the what are the retinal condition which can drive the glaucoma mechanism, and how do we prioritize our treatment. So we need to preserve the retinal function as well as control the IOP. That is the motto of the treatments. So it's quite easy. Neovascularization means you need to remember three entities very commonly we come across. One is the venous occlusion, and in that most commonly will be the central retinal artery venous occlusion, proliferative diabetic retinopathy, and the third is the ocular ischemic syndrome. So these three entities you need to remember as far as the neovascularization is concerned. Okay. Any clinching points from the VR fellows? What is the one feature you want to describe the CRVO? Exactly. Okay. And proliferative diabetic retinopathy. What is the one thing what you just want to say? Okay, it's proliferative proliferation. And how about the ocular ischemic syndrome? Yeah,
Mid-peripheral dot hemorrhages.
can be even little peripheral and mid peripheral. What sort of dot hemorrhage? Is it a similar one? Is it similar to the venous occlusion or a PDR? The shape, the size, the color, and the depth. All four features will have a little difference between the two. So the shape will be very classical. That round you don't see in the diabetic retinopathy. It will be little larger, round, discrete. It will make out. It will be little deeper, and it will be little dark. You can see those colors. Okay, these are little darker. And what is the differential diagnosis of this hemorrhages? If you see this photo, what is the differential diagnosis?
Decompressive retinopathy.
No, simple or common.
Diabetic retin, non-proliferative diabetic.
Sickle cell.
Something related to systemic. What's a very common such type of hemorrhages? You get confused. If somebody shows me, I will ocular ischemic syndrome versus one more. One is dangerous, one is not dangerous. Which is the non-dangerous?
Anemic retinopathy.
Yes. Okay. Fine, we'll go. So, neovascularization, the inciting factors are the hypoxia, which leads to ischemia, which leads to the VEGF release, and finally the neovascularization, which can occur on the retina or the iris or in the angle. These are the three structures which you need to remember when the neovascularization occurs. So, for a postgraduate, the treatment option for neovascular is only four. You need to remember four is one is laser, one is injection, one is cryo, and one is a surgery. Okay, these are the four common treatment modalities we come across. Which one will falls into that? We will go in depth right now. Okay, so the gold standard investigation for any neovascularization is always that, though clinically we do, it's the angiogram. Angiogram is the gold standard one to diagnose it. Why? Because one need to look for the CNP areas, and may have to sometimes tailor the laser spots. Okay, and macular status will be known. If there's a macular ischemia or a macular edema, you get to know that. And when you have a mild hemorrhages and you are not able to see the fundus, the angiogram gives you a clarity whether you are having any new vessels on the retina or not. That the treatment you can go for the laser accordingly. If you don't have an angiogram, then you need to, if you have a SSOCTA, and that can also sometimes give you some information, though not complete, but at least you can, if there is any contraindication for angiogram, SSOCTA in a larger montage images, you can still pick up all these findings. Okay, let's go to the case number 2. He's a young boy and who had a unilateral decreased vision of 4 months, and he was diagnosed elsewhere as NVG with a high pressure and already on maximum glaucoma, anti-glaucoma medication. What is cyclocryotherapy? Anybody knows? What is cyclo?
Ciliary body.
Cryo? Okay. So cryo application to the ciliary body is called cyclocryotherapy. he had underwent that, because I show the photo and it's a very classical photo. One can remember what does it shows. The vision was quite poor, and he had a vitreous hemorrhage and a cataract. Okay, so with the maximum anti-glaucoma medications and with the high pressure, the treatment option would be to plan a surgical intervention. Correct? What was the surgery done? The cataract has to go with a trabeculectomy and a vitrectomy and an endolaser. Till this time, we will not be knowing what's the cause of neovascularization, except he is young boy. So we need to have our differentials based on the age here. Correct? So on the table during surgery, intraoperatively, you come across to see this fundus. It looks like more of a vasculitis. Okay, so vasculitis is the second common cause of the neovascularization. Which type of vasculitis? Occlusive vasculitis. Common diseases. Name one, two. Who has finished glaucoma? Uvea. Which are the common occlusive vasculitis?
So TB, syphilis.
Okay. More threatening, something like this. Hope there is no uvea people here. Exactly. Okay. So first thing is more threatening. We need to address more aggressive. Fine. So he was treated with the uvea department with the azathioprine and oral steroids, and 6 weeks later also the pressure was little, not much control, but still it was okay. You see this. This is the very classical eye, the sclera. If you can differentiate, this is a sclera where the cyclocryo has happened. It's very, very classical one. One need to remember this photo. Okay. So the new vessels have gone, but the pressures were not controlled, and so they need to go for AGV with the anti-VEGF to reduce the ischemia and the VEGF rule. So coming to the neovascularization, the treatment options we have is the laser. Laser is the standard treatment of care. And when the view is clear, when the fundus view is clear, you can do whatever the laser you would plan to do, whether it's called an aggressive laser or 3 sittings or a sectoral, whatever you want to do. So we need to cover all the periphery, all the available retina in these cases of neovascularization. So little balance when you deal with a CR vivo. So when we do the peripheral laser, we need to keep in mind that there is a central macular edema or ischemia also, which is also the cause for the central scotoma. Central blurring vision in a CR vivo is due to the macular edema. And when you ablate the peripheral retina, you may have the peripheral vision issues, field issues. So you need to be little careful when you do the laser in these cases. And out of the 3 diseases, the laser responds more with the proliferative diabetic retinopathy. Okay. Coming to the anti-VEGF role, it's one of the again most important and an essential option. Right now, this is also one of the standard of care, and it also helps to. It is given. It is the injections are given complementary to the laser and the cryo. So what it helps in the eye, it clears the bleeding and makes the early visual acuity improvement. It reduces the macular edema. And the third component is that we give the injection prior to our VR surgery in these cases. So the third arm of the treatment modality is the ARC, that is anterior retinal cryopexy, which is an important option for new vessels. So this is very helpful when the media is very hazy. If you're not able to do the laser, you have the option of cryo. Okay. So anterior retina is ablated, and so cryo can also be added in spite of laser. Okay. Say especially a person who is senior residents doing VRE may come across. You will have a well ablated retina and still the pressures are high and still the new vessels are still there. So glaucoma will send you like what next to do. So still there is an option of the cryo. Cryo can go even up to the pars pliccata, pars plana area, and you can ablate it. Okay, so cryo usually done when you divide the retina into 4 parts. In each quadrant, you need to have certain cryo, like 4 to 6 applications in each quadrant you do. And it can be added along with the diode CPC, which we commonly do with it. Coming to the second part of the secondary glaucoma, that is the trauma. trauma or hemorrhage, and the glaucoma. So it causes an inflammation, there is a structural damage, and there is some pressure dysregulation. These are the three salient features in trauma cases. The main purpose of the surgery, VR surgery, in these trauma cases is to prevent the mixture of blood, lens, and vitreous. These three are quite friendly but in a devastating manner. If you mix these three and keep it in a bottle in about 4 weeks, it can really damage the eye at any point of time. So that is the main purpose you need to keep in mind. It prevents the fibrovascular proliferation at all the tissue level. The fibrous growth can occur on the ciliary process or on the retina in the choroid, and it can reach up to the scleral level also. That much of potential the scarring can have. So that is why in case of trauma, when there is a hemorrhage, we don't wait for a long time. We have to intervene between the 2 to 4 weeks, and which definitely helps in a long-term prognosis. And it's usually when we have to combine the high pressure with the trauma and VR surgery, we need to combine both the procedures together to have a good long-term effects. And what is essential in these cases? So the early vitrectomy is mainstay, and you need to clear the blood from the anterior chamber. As you see here, the anterior chamber, the angles will be filled with the blood. It will be stuck with the blood debris. So you need to really give a good wash, clean up all that area, the vitreous which is adherent to the angles also, and wash the blood from the angles. This helps to open up the ciliary process as well, and helps to prevent the permanent structural fibrosis damage to the ciliary body. Okay, something like this. When you have a glaucoma, high pressure, and the eyeball is like this. So whether we need to go with a surgery. So if we have to go with the surgery, it has to be a very, very aggressive surgery. You need to have the surface changes, and you need to go with the PK, you need to go with the VR, and is it worth of this? So you sometimes take the help of endoscopy, where we just give a attempt to see the disc, and if the disc is pale like this and or having a glaucomatous optic atrophy, you don't need to go with a further intervention. So this is how the endoscopy can help you in tackling this intractable glaucoma. And when you do an CPC, what we call endoscopic cyclophotocoagulation, we aim the laser burns towards the ciliary process, where we have a classical pop sound coming, and this is how we treat with the endo-CPC in these cases of intractable glaucoma. Okay. So the third component what I'm talking is about the vitreoretinal surgery. We do day in and day out the VR surgery, and what does its implication on the glaucoma. Correct. So VR procedures, if we can divide into two parts, one is the attached retina and one is the detached retina. And most common surgery we do for this is the diabetic surgery, which can have a glaucoma tendencies. So in an attached retina, you do a normal vitrectomy procedure, what we call VIT-MPEL, and without any tamponade. We have two situations coming across, whether the pressure can rise in your early post-operative period or is it in the late post-operative. So the early post-operative period is due to the really heavy laser when you do during the surgery. It can cause a thing. Hemorrhagic CD or a serous CD can also cause a transient early high IOP. And something which rarely we come across, posterior TAS. I think what is TAS? Yeah. Have you come across posterior TAS? So it's quite rare. We are surgeons should keep in mind of these things. So it also behaves like some fibrillary reaction in the anterior chamber, but you have a vitreous haze on the background. So that will all be taken care with the topicals and the intense topicals and the oral steroids. And early high post-op IOP can be managed with the anti-glaucoma medication. So the same procedure in a vitrectomy in a late high IOP. So what are the reasons? Most common reason in the late post-op, that is in the 6 weeks, is the inadequate laser. So if you would not have done the enough laser during the surgery, so you may land up with again the ischemic component and again the new vessels, rubiosis, and sometimes you would have left a lot of vitreous gel. If you see the second photo, you have a lot of vitreous gel left over. So this can also incite the ischemia and cause the secondary IOP. So treatment will be to ablate the retina further again. You do either fill in PRP or an ARC or give an injection or do a cryo to ablate the retina and then to stabilize the neovascularization. Coming to the retina vitrectomy along with RD surgery. So we need to tamponade. What are the two tamponates we use? One is a silicone oil and one is the oil. So what are the oil related early high IOP? So most common cause will be overfill of the oil. So overfill of the oil, what you do is to start with an AGM and we may have to do a oil tapping. So remove some of the oil, form the AC, the pressure will automatically come down. So around 6 weeks, what is a very common cause? You call the patient, attach retina, you call the patient, the pressures are high at that time. Most common cause at this point of time is this steroid use. You would have used the prednisolone topicals, so that would be the most common use. Sometimes you start with an AGM, it will be brought down. So the late complications of high IOP with an oil-filled eye is the emulsification, what you see, and you need to go for an oil removal along with some procedure. Coming to the gas related IOP changes, definitely the gas in the early postoperative period, you may have both the expansile and non-expansile can cause an high IOP. And that you need to keep in mind to measure the pressure very carefully and send the patient back home. One need to important is to remember that avoiding the air travel and sudden ascent to the hill range. So that is the very common cause of the high IOP, which can lead to the optic atrophy, glaucomatous optic atrophy also. Okay. I'll skip this because it may be challenging too much. So there are other situations where we come. Vitreoretinal surgery with the encircling band. If you do a belt buckle and do a heavy laser around the belt buckle and put a gas tamponade or an oil tamponade, that itself, the belt buckle itself can cause an edema at the peripheral retina, and it can have an interning because of the ciliary body inflammation and cause a high IOP. Though the oil is normal filled here, you may have a high IOP in these cases. So you need to recognize that it is due to the heavy laser and the encircling band, not due to the overfill. So it can be managed with a topical medication. Schwartz syndrome must be knowing everybody. So it's just more of a name rather than anything more. So it is just a temporary IOP rise. It does not have any implication on the post-surgery sequelae. After you settle down the retina, it does not have much implication. So when you do a buckle, you have again two situations. One is the early post-op early IOP rise and or the late IOP. Early IOP will be more due to the excessive cryo. Okay, excessive cryo, excessive laser you do, and sometimes non-drainage buckles will have a high IOP. Angle closure can be there if there is a associated trauma in the past history, and it can be managed with the topicals. So the late high IOP in a buccal case is more of a steroid induced, or it can be unnoticed post-trauma cases where you do a buccal. Okay. The role reversal is that a glaucoma surgery has been done and a vitreoretinal procedure has to be contemplated. So what are the things you need to keep in mind? You need to have a very detailed discussion with a glaucoma specialist for you to plan a procedure, because we may have to open the conjunctiva, we may have to do our section. So a lot of things, when there is a trap functioning, bleb functioning, tube is there. So we need to have a very careful discussing with them, like where to do, what not to do, and then go with the procedure. So they usually write, you would have seen that careful conjunctival planning or during the peritomy is a common thing. Especially when you do a SF5 oil along with a trap surgery, you need to really make a minute or inch to what you call millimeter to millimeter planning of your surgery, where to place your cannula, where to place your flaps. So in case of a post trab or a post AGV, we need to avoid the encirclage or the buckles. And endo-CPC, if you are able to see the fundus, you can do an endo-CPC during these procedure. And one has to avoid the cryo in a functioning bleb. Anybody can just explain what is malignant glaucoma with this picture? Can you just tell how the fluid precipitates to the formation of malignant glaucoma? What is malignant glaucoma? Where is the misdirection here?
Posterior.
Okay. So this is the anti one. Where does it go? Going posteriorly. Where does it go posteriorly? Does it get mixed with the vitreous, or does it go subretinal, or where does it go?
Supraciliary space.
It's photoischeme. That's why I'm putting this very particular photo. If you understand this, the whole malignant glaucoma will be easy. So it goes between the, yeah, it goes between the posterior hyaloid face and the retina. So what happens? This fluid goes and pushes the retina, pushes the vitreous forward. Okay, so if you understand this, then the treatment would be more easy. It's not as simple as, okay, you do a little anti-vitrectomy, the malignant glaucoma will resolve. So this thing, where does the vitreous attachment comes and why it is not pushing up, that's the thing what we need to understand in malignant glaucoma. So we basically, for the treatment, we create a communication between the anterior segment and the posterior segment, but lens is the in between the thing. So we need to address the lens also. And there are situations where when there is a clear lens, and can we manage without compromising the lens, or we need to sacrifice the lens. Okay, these are the two situations you will come across. The procedure is called iridozonular and hyaloidotomy, IZH. Okay. So the option will be to have the two surgeries. One is either directly go onto the periphery, you create a path, and this is along with the cataract surgery. Surgery was taken from Dr. Pramod Bende, and Dr. L. Vijaya did the other part of the surgery. So once we see this, so the PVD induction is one of the very, very important structures. So an ideal way to manage is by the VR surgeon rather than the anterior segment surgeon, because as a VR surgeon we are supposed to go, show you the next video, we have to induce the PVD. As you saw the schematic diagram, only when the vitreous is coming out of the retinal surface, then only the space will be created. So a PVD induction is a part of the malignant glaucoma. You cannot just have a small anti-vitrectomy and get away with that. Okay, we have covered. So limitations. So anterior approach is little limited unless you are versatile or you are little experienced to go with the periphery and then create a chamber. You need to have a multiple openings. It's not little one go, you go and then come. You should have a multiple, because it can easily get blocked. So finally, the takeaway from the retinal point of view is that the glaucoma people requiring the retinal support, you have more of a medical retina condition, whereas a retina people requiring the glaucoma support, you have more of a surgical conditions. Okay, so ultimately it's preserving the retinal function while controlling the IOP is your objective of your treatment in these neovascular glaucoma, in these secondary glaucomas. Thank you.